Hello, good afternoon, everybody. Firstly, I'd like to thank you for taking time out of your busy schedules to join us for this webinar, in which we will be talking about the impact of menopausal hormone therapy on cardiometabolic disease risk. So with that, I will commence. First off, I have to share with you my disclosures. I have received support from Besson's Healthcare. I'm a consultant to oncology in Maine, but most of my research funding is from competitive grants. So the learning objectives here are to define cardiometabolic disease and its prevalence and understand it, and the impact of hormone therapy on this. So we normally talk about cardiovascular disease or metabolic disease, but this term of cardiometabolic disease was initially coined by Pescatello, who's an exercise physiologist. And he really expanded the idea to basically incorporate the cardiovascular risk with insulin resistance. And we know that for many situations, these are inextricably linked. So when we talk about cardiometabolic disease, we're often referring to vascular disease and type 2 diabetes. And we see this manifest in people with abdominal obesity, hypertension, dyslipidemia, and insulin resistance and glucose intolerance. And I think this is a very useful terminology rather than just using sort of metabolic disorders or the metabolic syndrome. So cardiovascular disease remains the leading cause of premature death in women globally. And this is looking at the probability of premature mortality due to cardiovascular disease from 1990 predicted out to 2025. And basically, the green line extending is what would happen if all risk factor targets were met. However, what globally would have the greatest impact for women would be reducing systolic blood pressure. And that's something that really is achievable internationally. But where we see disparities is between high-income countries and other countries. So here we're looking at, again, the probability of premature mortality in high-income countries and Eastern Europe and Central Asia. And if you see, back in 1990, the probability for premature mortality due to cardiovascular disease was almost a third of that of what we were seeing in Eastern Europe and Central Asia in the 1990s. If basically things keep along the current trend, the scenario for developed countries is that the reduction will be equivalent to actually reducing all risk factors, and this is because of heavy interventions that's happening in these countries. On the current trend of improving risk factors, we're not even going to reach the rate of lower risk seen in high-income countries in Eastern Europe and Central Asia with the best case scenario. This is the green line is showing that if all targets of risk reduction are met, the risk of premature death is still going to be far in excess in these countries compared to what it is in high-income countries. So bottom line is there is enormous disparity across the globe in cardiovascular disease risk in women. Then the other issue when we talk about cardiometabolic disease is the risk of progressing to diabetes. And this graph looks at, for men and for women, on the x-axis, the age standardized prevalence in 1980, and on the y-axis, the prevalence in 2014. So if we look at men initially, anything on this side of this line means there's been a reduction in risk or prevalence. Anything above that line shows the prevalence of diabetes is increased. And this black dot is in fact the world prevalence overall. And globally, the prevalence of diabetes in men between 1980 and 2014 has doubled. And that has occurred in the majority of countries. And as you can see, very much in Asia Pacific, Sub-Saharan Africa. The effect has been less in Oceania and high-income countries. What about women? Well, the effect's been a little bit less. In fact, there have been some countries where the prevalence is indeed decreased, and the prevalence has increased globally, but not at least doubled. So the take-home message is that globally, diabetes is increasing. It's at least doubled in men. It's increased but not at least doubled in women, with some countries showing a reduction in risk in women. That all seems very positive, but the thing we must be mindful of is that if a woman develops diabetes, the adverse effects that she's going to experience are more significant. Oh, I'm sorry, it's jumping around. My apologies. Are more significant than what you will see in men. So this is comparing the relative risks of vascular events or adverse outcomes for women versus men with diabetes. So any kind of diabetes, women are far more at risk than men of developing coronary artery disease, having a stroke, progressing to end-stage renal disease or vascular dementia. And much more significant if a woman has type 1 diabetes compared to a man. So although the prevalence increase may not be as extreme in women across the globe, certainly we still have to deal with the fact that when women develop diabetes, the consequences are more dire than for men. Okay, so what are the factors that contribute to women being obese and having elevated cardiometabolic risk at menopause? Well, you know that estrogen insufficiency has consequences. Women are less likely to be physically active, and that's for a range of reasons. Plus, there are genetic effects of estrogen insufficiency directly on the genome. Estrogen results in increased muscle insulin resistance. Most of glucose disposal happens in muscle. So if the muscles become more resistant to the effects of insulin, you progress to type 2 diabetes. And estrogen has a direct effect through ER alpha on muscle insulin sensitivity. And these are mitochondrial effects as well. Women who have estrogen insufficiency have reduced satiety and increased food intake. And a classic example of that is seen in animal models like the estrogen deplete aromatase knockout mouse. In that mouse model, the mouse eat more and move less. The sleep deprivation we see with low estrogen and vasomotor symptoms results in desynchronization of clock genes throughout the body. So our clock genes in the liver and the gut are harmonized with the brain. So and all the clock genes in different cells are harmonized. So when you eat at erratic times, you cause dysynchronization. Or if you sleep erratically, you cause dysynchronization of the biological clock in different cells and different tissues. And that causes abnormal metabolism and weight gain. And ultimately, this all results in fat accumulation centrally, fatty liver, which is increasing globally, insulin resistance, reduced HDL cholesterol, increased LDL cholesterol, triglycerides, and inflammation. So Miles Fisher wrote this paper back in 2016 describing what would be the most ideal cardiometabolic disease preventive intervention. And he listed these effects that such a drug should have. It needed to prevent abdominal obesity, improve lipid profiles, reduce insulin resistance and improve glucose tolerance, have favourable vascular effects, particularly on endothelial function, and have favourable effects on circadian rhythms. What does that mean for hormone therapy? Well, before we move on to that, one of the things I'd like to highlight in terms of cardiovascular risk is this study which looked at women with a normal body mass index, but women who then had excessive trunk fat with a normal BMI and low leg fat with a normal BMI, and women in that situation have a threefold risks of cardiovascular disease. So women with skinny legs and fat central abdomens are at threefold risk of cardiovascular disease compared to women with a pear-shaped premenopausal voluptuous Rubens body. So going back to the perfect cardio-metabolic prevention drug, how does hormone replacement therapy fit into this? Well, this is a study looking at waist circumference and abdominal fat. And in these randomized studies, hormone therapy was in a meta-analysis associated with reduced waist circumference and less abdominal fat. And this was statistically significant. This is data from a study conducted several years ago called the Hearst study, and many of you may or may not remember it. This was a secondary prevention trial, so women had to have pre-existing cardiovascular disease, and the question was, would hormone therapy prevent recurrent cardiovascular events? Women randomly allocated conjugated equine estrogen with or without Provera, medroxyprogesterone acetate according to their hysterectomy status, and followed for 3 years. All the solid lines are placebo and the dotted lines are the MHT group. And what you can see is the women who are on placebo gained more weight, on average a kilogram more, had a greater increase in their waist circumference and a greater increase in their hip circumference over the 3 years than women treated with hormone therapy. So hormone therapy ameliorates some of the effects of menopause on central abdominal fat increase. This was a separate study conducted by Ken Ho's group in Australia in Sydney, and what Ken did was randomise women to either oral conjugated estrogen, 1.25 milligrams, or a 100 microgram transdermal patch for 6 months, and looked at weight, fat mass, and lean body mass. What he found was that both groups had about a half a kilogram increase in weight over the 12 months, but the women on oral estrogen had a greater increase in fat mass of about a kilo, whereas the transdermal treated group had no significant increase in fat mass, and the oral estrogen group had a reduction in lean body mass, not seen in the transdermal group. Oral estrogen significantly reduces IGF-1, and this potentially may explain the reduction in lean mass seen with oral estrogen. They also looked at other factors that may have caused this discrepancy in weight gain, fat gain, and lean mass loss. What they found was that there was no difference in energy expenditure after a standard meal, and this shows the energy expenditure here in figure A, but rather that oral estrogen suppressed lipid oxidation with a reciprocal increase in carbohydrate oxidation within an hour after a standardized meal. So there's the reduction in lipid oxidation and the increase in carbohydrate oxidation with oral estrogen compared to transdermal therapy. So there seem to be some favorable metabolic aspects of non-oral estrogen over oral estrogen therapy. What about lipid effects? Well, this would be known to many of you that estrogen therapy reduces total cholesterol compared to controls. However, oral estrogen increases triglycerides and VLDL cholesterol, not seen with either intranasal or transdermal estradiol. They all modes of delivery reduce LDL cholesterol and all increase HDL cholesterol compared to controls. So, favorable overall metabolic effects or lipid effects, although we do see this increase in triglycerides and VLDL with oral estrogen. This is a systematic review and meta-analysis looking at the hormone replacement effects on components of the metabolic syndrome, but particularly the LDL to HDL ratio and percentage change in triglycerides. Now, these studies do not discriminate between the modes of delivery. Overall, there was an improvement, so a lowering of the LDL to HDL ratio, and no significant effect on triglycerides, but this is combining, as I said, studies of oral and non-oral estrogen. What about insulin resistance and glucose tolerance? So this is a study that looked at the effects of estrogen on glucose disposal, which, as I said, primarily is in muscle. At baseline, untreated early postmenopausal and late postmenopausal women had no difference in their glucose disposal rate into muscle. But once they were treated with high-dose estradiol, and note this was very high dose of 150 microgram patch for a week, there was a crossover design, that the early menopausal women actually had an improvement in the capacity to dispose glucose in their muscle. This was not seen for the women who were late menopausal. So this is consistent with what often is described as a window of intervention hypothesis, where early intervention is effective compared to late intervention being ineffective. This is a really interesting study, I think, published in Cell last year. And basically, estrogens are known to prevent diabetes in women, but the mechanism has been poorly understood. However, there's extensive evidence that estrogens might protect pancreatic beta cells, so islet cell survival and function in animals and cultured human islet cells. And what this study showed was estrogens actually activate endoplasmic reticulum-associated protein degradation pathways and promotes the accumulation of misfolded, it reduces the accumulation, I apologize, of misfolded proinsulin. So when proinsulin is secreted into the pancreatic or made in the pancreatic beta cells, it's folded, but if it's misfolded, the insulin won't work and you get insulin resistance. And with insulin resistance, you get loss of integrity of the secretion of insulin and more misfolding. But estradiol somehow protects against this. What they also found, which was fascinating, was that the effects of estrogen were consistent in the male and female animals. But there was an effect of basidoxifin that was specific to the female animals. And it's believed to be explained by the fact that the effect of the selective estrogen receptor modulator in the cells depends on the overall estrogenic milieu of the cell, and therefore it's a favourable effect in females, but has no benefit in males. So I would watch this space because there was a lot of interest in this particular paper. What about vascular function? Well, it's been known for decades that estrogen improves endothelium-dependent flow-mediated dilatation after menopause. So after menopause, the effect of constricting and releasing pressure on an artery, which then should result in arterial vasodilation, is diminished. And this is restored with estradiol. This is called endothelial vasodilation. And this has been known for many years. What about women at cardio-metabolic risk? Well, this is a study we conducted many years ago. And we looked at women who had elevated LDL cholesterol to the extent that they would be, it would be appropriate for them to be treated with a statin. And we randomized women to pravastatin or 17-beta-estradiol with norethistron for 24 weeks. And we looked at the endothelial function. And we found, compared with baseline, there was a significant difference in endothelial beneficial effects with estradiol, but no benefit was seen with pravastatin in these women with hyperlipidemia. So the beneficial effect held for estradiol in women with hyperlipidemia. However, the benefit was much more modest than is seen with women with normal LDL levels. And what about sleep? Well, this is a systematic review and meta-analysis on sleep quality and hormone therapy. The studies looking at women with no vasomotor symptoms required as an inclusion criteria did not show a significant benefit on sleep quality, although these studies were considered to have provided low-quality data when assessed by a risk of bias tool. However, the studies that required women to have vasomotor symptoms at inclusion showed a moderate improvement on sleep quality compared to placebo with moderately good quality data. The overall effect was non-significant, but for women who had vasomotor symptoms, not surprisingly, menopausal hormone therapy improved sleep. So Miles Fisher went on to say that the gold standard would be proven reduction of cardiovascular events in a double-blind randomized placebo-controlled trial, and the Women's Health Initiative kindly did that for us. So in the estrogen-only arm of WHI, for women who were aged 50 to 59 at randomization, there was a reduction in coronary heart disease and a significant reduction in the hazard ratio and total myocardial infarctions, a reduction in death, and a global index reduction, only seen in the women that we would normally treat with hormone therapy. Interestingly, this effect was not seen until several years post-randomization. So across the study, women on placebo were less likely to develop coronary heart disease if you look at all women across all ages. If women were less than 10 years from menopause, there seemed to be a benefit that emerged just after 6 years from randomization. And for women more than 10 years from menopause, there was no clear benefit. So this is seen in this other meta-analysis. This is death from cardiovascular causes and non-fatal heart attacks and all-cause mortality. For women less than 10 years from menopause, you get a reduction in all-cause in cardiovascular deaths and non-fatal infarcts and all-cause mortality, not seen for treating women more than 10 years from menopause. And we're talking about cardio-metabolic disease, so we also need to look at type 2 diabetes. And what was seen in both Women's Health Initiative arms, that across the course of the studies, women were less likely to progress to type 2 diabetes. The incidence here was less in women with estrogen plus progestin therapy compared with placebo, and estrogen only compared with placebo. So now we've fulfilled most of the criteria that Miles Fisher talked about. And for maximum applicability, it should have no side effects or contraindications. Well, I don't think there's such a drug if we look at blood pressure medication, statins, anti-diabetic medications, aspirin, and the use of aspirin is dubious anyway. There's no drug to my knowledge that has no side effects or contraindications. But what can we tell women about the safety? And this is looking at the number of deaths annualized from the combined Women's Health Initiative trials that together the hormone therapy trials included over 27,000 women. And we can look at the intervention phase, but more importantly, I think, is the 18-year cumulative follow-up. And you look at the total number of deaths. For the pooled cohort with the 18 years of follow-up, there was no increase in the number of deaths across the board. For women who had estrogen only, and this is looking at the younger women, there was a statistically significant benefit in the number of deaths up to 18 years of follow-up. So I think you can really confidently say to patients, yes, you worry about breast cancer, although it's not increased in this arm of the study, and yes, you might worry about various things, but in fact the all-cause mortality is lower at 18 years. For women who got estrogen with progestin, there was no increase in mortality over placebo and no decrease. So when you take into account the benefits of symptom relief, this really has to be a winner in terms of therapy. And in the final couple of minutes, I do want to consider the potential benefits of non-oral estrogen in women who have adverse cardiometabolic profiles. And I have alluded to this already. So during this presentation, I emphasized the fact that non-oral estrogen therapy will increase triglycerides and VLD cholesterol. Oral estrogen therapy will increase triglycerides and VLDL cholesterol to a small degree, but that becomes much more potentially problematic in a woman at high cardiovascular risk. Now, Jim Simon and colleagues completed this really interesting study a few years ago, or published it. What they looked at was health insurance claims from 60 different self-insured US companies from 1999 through to 2011. They looked at women who were at least 50 years of age and who had been newly initiated on either transdermal or oral estrogen during the course of the study. Women were matched 1-to-1 based on exact factors and the propensity to develop disease. And what they were able to do was compare the incident rate ratios of cardiovascular complications, such as thrombosis and other cardiovascular events, through conditional Poisson models. And here we can see the effects on these outcomes of being on transdermal or oral estrogen. So anything on the left of the graph favors the use of oral estrogen. They looked at all events and hospitalization events. With respect to all events, women who received transdermal estrogen were less likely to have a cardiovascular disease occur than women who received oral estrogen. They were significantly likely to have a thrombosis of any sort or a DVT. There was no difference actually in PEs, although the numbers were small. They were also less likely to develop congestive cardiac failure. There was no statistically significant difference in hospitalization-related events. So this suggests benefits of transdermal over oral estrogen. This is looking at stroke, comparing different forms of therapy with placebo or no therapy. And what this study showed, that using the overall with the transdermal route, cases compared to controls and the crude and adjusted risks, that with estrogen only, or estrogen plus progestin, if the estrogen was transdermal, there was no increased risk in stroke. This is overall. In contrast, there was statistically significant increased risk of stroke with oral therapy. Now, when they broke down the doses, the women who received 50 micrograms or less transdermally, equivalent to a 50 microgram patch, had no increase in stroke risk, but a stroke risk started to emerge for women who had estradiol patch doses greater than a 50 microgram per day delivery system. So 50 micrograms or lower, there's a benefit over oral therapy compared to over 50 micrograms, there doesn't seem to be any benefit compared to oral therapy. And this was the UK GP research database. And we must always take into account obesity. Now, if we look at non-hormonal therapy use, so the risk of VTE in non-users increases progressively from normal BMI to overweight to a fourfold increased risk in obese women. If you use transdermal estradiol, there's no increased risk in VTE in this particular study compared to non-use when obesity is taken into account. But with oral estrogen, there's a progressive increase in use such that in an obese woman, you really shouldn't be using oral estrogen therapy. And I'm sure most of you don't. So the key messages are that hormone therapy remains the most effective treatment for menopausal symptoms. Although not a primary indication, the data really stacks up that menopausal hormone therapy offers cardio-metabolic protection, particularly in women who commence in early menopause. Non-oral estradiol should be used in women with more adverse cardiometabolic profiles. And I did not discuss this, but there is no set stopping time, and treatment should really be used for as long as clinically indicated. I'd like to remind you that the EMAS has videos online that you can share with your patients. They are all in English, but also now in Vietnamese and Cantonese and Mandarin. And they're available on YouTube. And finally, this presentation would not be complete without my warmly inviting you to Melbourne for the World Congress on Menopause in 2020. It's been gorgeous weather here today. It was 31 degrees, lovely sunny weather. The Congress will be fabulous. The city's gorgeous, and it's not really nearly as far as you think. So I look forward to seeing you all in Melbourne. And thank you for your participation. I'd be happy to answer any questions you have.
Yes, thank you very much for such a wonderful presentation. And now it's the time for the questions and answer session. So please feel free to ask your questions in the chat box, and then we will answer them. So we are waiting now. So as I can see, there is no questions so far. So thank you
Okay,
very
that's
much
fine.
for everyone for. So we don't have questions. So thank you very much for the presentation,
My
Dr.
pleasure.
James, and all the attendees for being here today. So you will have an access for the recording in the EMAS website. So thank you everyone again, and have a great rest of the day. Thank you.
Thank you.